Is there feedback? Do I need to move it? All right. We'll go ahead and get started. I've got an eye-opening topic here, obviously sleep and fatigue. So it's about, I guess it was about 10 years ago, I got a call from my old program director, Rick Jordan, who asked me to tackle the subject of sleep and fatigue. And I knew absolutely nothing about it except for when I was in residency, I was always sleepy and I was tired. That was my extent of knowledge of this subject. Put together this talk. It's evolved over the last... Am I doing something wrong? Okay. It didn't sound good. All right, so I need to stay away from that? Okay, yeah. All right, so I put this talk together. It's evolved a lot over the last... Is there a speaker over here too? Am I going to have to stand still? Okay. Yeah, let's go. I can't stand still, Dan. I'll go crazy. All right. So one of the things I wanted to learn about was the myths of sleep that I'd heard growing up, and you know, when I'd stay out all night in college, and my mom would tell me, "Oh, you can't ever get that sleep back," or I would try to take little naps during the day. Oh, don't nap during the day, then you won't be able to sleep at night. Those type things. So I'm going to try to dispel those myths for you and teach you a few tricks to help you whenever you need rest. Are power naps good? Is it better to sleep longer or shorter? If you're working on an all-night shift, is it better to sleep before the shift or after the shift? I would say that it's better to sleep during the shift, and hopefully you don't get any patients, but that hardly ever happens. So I'm going to try to cover those things. Hopefully it'll be practical. I'm also going to teach you about the prophylactic use of caffeine. Caffeine is a wonderful drug, and I'm a big fan. Okay, but you need to know how to use it. All right. And hopefully this will be something practical that you can use in your residency. All right, and that's not good there. All right, so I'm going to give you a historical perspective on how we got here with resident duty hours. There's a case called the Libby Zion case, originated in New York City in 1984. That's really the impetus for resident work hours. And we're the only, that's what I was telling my young student Zach over here on the way over, we're the only profession I know that limits ourselves to 2 full-time jobs. All right, 80 hours is 2 full-time jobs. And we feel like we've made progress. I guess we have. We're not working 100 hours in residency anymore. But I still think that there's some work to be done here with regards to resident duty hours. But I want you to understand the historical perspective of how we got here. We're going to look at the risk and impact of sleep loss for residents, faculty, and patients. Residents are in a bad position. If you get up against your duty hours, you're tired, it's very dicey for you to say something. You're afraid of your evaluations and everything else in the world, and that's on us as a faculty to do something about that, because if you're working fatigue, then you're not in the peak condition to be taking care of patients, and errors can happen. The numbers say that each year we kill between 100 and 200,000 people in our hospitals due to preventable medical errors. How much this sleep and fatigue issues figure into that? Very hard to tell, because nobody's got a stopwatch on you. Nobody's making you punch a time clock. So I think we have to start to use our heads, and we have to be more in tune with helping each other out whenever we are fatigued without taking advantage of the situation. And then the last thing, I want you to adapt some strategies to manage the effect of sleepiness and fatigue. Again, I'm going to go over naps, when the proper time to nap is, and the wonderful drug of caffeine. Okay? All right, so this was the first thing. I went to Duke University's website. I searched, sleep and fatigue, and this is the first thing I saw. Sleepiness comes from lack of sleep. I said, well, no shit. Really? Thank you. That's very helpful. But if you think about it, that statement is not altogether bad, because I've got residents and I work with folks that think that they can get rest just by sitting around and watching TV, right? And when you're off service, as long as you're not actively doing something, if you're just hanging out, you're laying on your bed reading or whatever, that's not sleep. Right? Sleepiness does come from lack of sleep, and we need so many hours of sleep a night as human beings. So that statement wasn't as ridiculous as I thought it was. Daniel, is there any way I can see my top part up here? I'm not sure either, because up here it's fine, and there it's not. I'll have to stand here. I'm going to know what's coming up. So implications of sleep loss. When I was in residency, and Dr. Stewart, Dee, did you come through with work hour restrictions? All right, so we were all in residency when we did not have work hour restrictions. And it's not one of those stories of walking uphill both ways in the snow, year round. We didn't do that. But I can tell you that sleep was a factor. Does anybody know what we used to spend most of our time in the hospital doing? And I'll bet you did too as well, Dr. Stewart. When we were preparing for rounds, what was the number one thing we spent time doing? chasing down x-rays. We chased down x-rays all the time. All right, so it was always a battle, and I would always try to get down there early and get the x-rays so the surgery residents wouldn't have them, and I'd keep them, all right, because I may need them and I didn't want them to have them. So there's all these things that we were doing in residency we don't have to do now that we've got computers for. You know, you can pull up your x-ray at any time. You never have to search for those things. So we need to start to use the downtime we have more wisely. We didn't have those options. We would routinely work a 24-hour shift, and then you would wait till rounds, after rounds, until you got off the next day. And a lot of times that bled into the afternoon, and at the VA it bled into the early evening. Okay, so we had to endure long work hours, and we did this literally for 100 years. Abraham Flexner wrote his report on medical schools, I think in 1911, and it took us 100 years to figure out that we shouldn't be working more than 80 hours a week, and we're supposed to be the smart guys. Impact on resident and patient well-being was recognized. Obviously, if you're in much better shape to take care of somebody if you've had 8 hours of sleep as opposed to if you've been up for 35 straight hours. I mean, that's although there's nothing in the data that I know of right now, and maybe Dr. Stewart knows, that has shown that resident duty hours have had an impact, particularly with regards to sleep and fatigue, on patient safety. But it makes logical sense. The ACGME mandated duty hours for all residents, all specialties, all locations in 2004, 2003, 2004. 80 hours, and you all know what the breakdown on that is now, probably better than I do. Now, whenever they first came out, said, well, this doesn't count for fellows. Yes, it does. If you are anything other than an attending physician, resident duty hours apply to you. If you have an attending that does not believe that it applies to you, then that's something that your program director needs to know. Okay, we have to be responsible as a faculty to follow the guidelines, and I think they're very good guidelines, and I think they're in place for a reason. Sufficient sleep and good sleep hygiene are crucial for the practice of good medicine, just like it is driving a car. I don't know if any of y'all have ever seen those videos they do of showing people who have been up 24 hours and they're driving. They put them out there on the course with the cones. The people who've been 24 hours without sleep drive worse on those cone tests than drunks do with a 0.08 blood alcohol level. So when you're driving with sleep issues, when you haven't slept, you're like a drunk driver on the road. As a matter of fact, New Jersey actually has a law, Maggie's Law, that they can hold you criminally accountable for driving under the influence of lack of sleep. Okay? And that's only in New Jersey. I don't know of any other state that has that law, but it is absolutely essential to the practice of good medicine. And both of these things are good for patient safety. Now, no matter what kind of things we do with resident duty hours, we're not going to fix this problem because you guys get to do what you want to in your off time, as well you should. So I put this slide in several years ago. I used to see the residents out at the Electric Cowboy all the time. I don't even know if that's still a bar in Johnson City, but you're going to be doing other things. I've got residents in here. I've worked with Adams. Adams is young, married, with a family. You guys have families. Okay, you work a lot, and then you have to somehow figure out that family time. So when you go home after a long shift, you haven't seen your family in a day, particularly if you're on night float, maybe you haven't seen them in a week because your hours haven't crossed up, then you've got those family obligations. Guys, this is a delicate balancing act. And I can tell you that when I came out of residency and went to work here at ETSU, I let that balancing act get out of kilt. I spent so much time in the hospital working, fatigued, working myself into the ground. I neglected my family responsibilities. I really lost contact with my wife and kids and got really lucky that I didn't lose them. And then I also had substance abuse issues as a result of some of that. So I'm asking you not to go there. This is a balancing act. And there are going to be times that you get home in the evening and your kids are going to want to play, your wife's going to want to go to dinner, that you need to go to bed. That's just part of it. And you're going to have to learn how to balance that. You cannot sacrifice sleep. It will not work in the long term. This slide was another one from Duke, and I loved it. The guys at Duke get published for doing really things that are amazing. It's like when I found out in a New England Journal article that got published that said the more organ systems you have failing at one time, the greater your mortality is. And I was thinking, geez, Pete, how come I didn't think of that? This one says it's well known that sleep deprivation and disruption of normal sleep pattern can severely impair function. Again, I told you about the driving test, and that's just driving. Think about it if you're a surgeon, okay, or what we do every day. We make hundreds of decisions each day. All of us do. Interns, you have a horrible life. Okay, the phone never stops ringing. Your pager never stops going off, although I'm very pleased that I haven't heard pagers going off in here so far. you get interrupted a numerous amount of times each day, and then you have to refocus back to your task. The only way that you can really keep on top of that is to be fresh and rested every day. There was a study done that showed the average number, or the number of times that an intern is interrupted in a 24-hour cycle. I love this study. All right, so somebody tapping you on the shoulder while you're writing, a phone call, a page, any interruption, and they followed this group of interns around for a long time, and then they calculated how many times they were interrupted in a 24-hour cycle. The interns in the room, how many times do you think it was? Guess, Haruka? You want to guess? 100? So 200? All right, anybody else? Yeah. I was going to say, Charles, you're probably more along my guess. It was between 350 and 400 times. All right, so that's a lot of times to be interrupted and then have to refocus. Think about trying to do that. You know how hard it is to try to read a book whenever you're sleepy. It's very difficult. Now you've got to be doing something, get interrupted, and refocus. And guys, the only way that you can do that consistently is be rested. Now, there's just no question about it. So I want to talk to you about the Libby Zion case. This is really the impetus for ACGME work hours. Libby Zion was a young 18-year-old college student in New York City in 1984, in March of 1984. And she went to the ED. Now, she was being treated for depression with a drug called phenelzine. I don't even think we use phenelzine anymore. And I don't even know what the trade name of it is. But she's being treated for depression with a drug called phenelzine. And she had questionable history of substance abuse. Not a documented history. She hadn't been to rehab or anything like that. But there was a history of substance abuse that was noted in the ED doc's notes. And she's having these weird shaking movements. Okay, she comes in, the ED doc is in the evening around 5 o'clock. The ED doc diagnoses her with a wonderful viral syndrome and says she needs to be admitted to the hospital service. And their hospital service at that hospital in New York is set up just like ours are. They had one attending physician, one senior resident, and 2 interns. Now, it's after 3:30, so on call was a senior resident and an intern, just like we have, and an attending physician who's not in the hospital. The intern evaluates the patient along with the senior resident. They decide that, yes, this is a viral illness. They give Libby, who is 18 years old, they give her some fluids, and they give her meperidine. Does everybody want to know what meperidine is? Right, it's a narcotic, okay? It's a narcotic opiate pain medication. I guess that's the treatment for acute viral syndrome. So, unaware at the time that phenelzine and meperidine cause something called serotonin syndrome. It wasn't widely known then. There had been cases reported. Actually, this case is the reason that drug interaction now is widely known. But they gave her meperidine, okay, and sent her up to the floor. They contacted their attending physician who was at home who agreed with the treatment plan. Now, each of those residents, the intern and the senior resident, was responsible for the ongoing care of 40 patients overnight, okay? No attending in-house. The intern is, a little more than halfway through their first year of residency, and the senior resident is a PGY2, so we don't even have a PGY3 in the house. So they go on about their business. The senior resident goes up to the call room, and the intern goes about to do intern things. 3 hours later, they get a call from the floor staff that Libby is becoming more and more agitated. So instead of going and evaluating the patient like probably should have been done, the intern responds over the phone, put her in 4-point restraints. So they put Libby in 4-point restraints, and the intern goes back about her business. She did not call the senior resident. She did not call the attending. About 3 hours later than that, while the patient is in restraints, she continues to be agitated and not falling asleep. The intern responds with give her another dose of meperidine. Okay? Again, no contact with the senior resident, no contact with the attending. And guys, that's not unusual at all. It happens all the time. It happens now. And in our day, it was pretty much standard here. I mean, we just didn't have the involvement or oversight like we do now. So at 6 a.m., the intern goes through the night, doesn't hear anything else from Miss Libby Zion. And at 6 a.m., the nursing staff calls and saying that she's shaking uncontrollably, and her temperature is 107 degrees. All right, she goes into cardiac arrest, and she dies. And the attending still has not seen the patient. The resident and intern are in the hospital. You know their level of training, and they tell Libby's father, his name is Sidney Zion, that there's really nothing that they could have done. Does anybody want to guess what Sidney Zion's profession was and still is today? He is a lawyer, and he is a well-connected lawyer. He is a writer for the New York Times. and he did not buy that explanation. And this case went on, actually it wasn't tied up really until 1995. But Sidney Zion looked at the system and was like, this is crazy. How in the world can you work people this many hours and expect them to make good decisions? And how in the world do you have people with this level of training responsible for the oversight of patients without someone higher up paying closer attention to it? So this really was the impetus for all the ACG, or for a lot of the ACGME changes that we've seen, particularly in the last 15 years. Now, I will tell you that as the case went on, the resident and intern actually had 38 counts, 38 criminal counts brought against them by a grand jury in the state of New York. And the doctor's records were expunged from all of that, but it took a number of years for that to happen. I think that would be very hard to do in our environment today. Residents are not culpable for anything because of the oversight that we have. Sidney Zion wound up pressing the case forward. Obviously, it was the impetus for the ACGME duty hour changes, the known drug-drug interaction now between phenylazine and meperidine for serotonin syndrome. And he was awarded $375,000 in 1995, which is 11 years after he started working this. So that is the Libby Zion case, and that is basically the impetus. The grand jury, though, was pretty telling here, because they didn't say anything about work hours. They said the most serious deficiencies can be traced to the practice of permitting interns and junior residents to practice medicine without supervision. And guys, those of you who know me, I know Hark and Adams are the closest ones that I've had lately. I don't know if Jennifer's here or not, Bimister, but that's why, is she here? Oh, hey, Jennifer. I didn't see you. But that's why we're trying to change the culture of what's going on in our residency programs. Jonathan Pollitt and I were interns at the VA in 1998. We had an attending we saw once that month. I'm not talking once a day. We saw him once for the month. We admitted and discharged patients right along through every day, and we would see notes from him, but we never saw him. He didn't hold rounds. We rounded with our senior resident, who was Ferris Cotter. Right? That's what we did. Guys, that model does not work. That model is not good for residency training. The interns in the room, you guys were medical students 2 months ago. 2 months ago, right? You were running around somewhere, Adams, doing God knows what, because we know nobody does anything in the fourth year of medical school. So you don't have the experience. Getting involved in administrative wars in the hospital is not what you need to be doing. These things need to be handled by our attending physician. So while the Libby Zion case is credited with the work hour restrictions, it's interesting that the grand jury didn't say anything about work hour restrictions. They said everything about resident supervision. The VA at night, second-year residents in the ICU. Okay, that is Calpert, you're in there right now, right? The supervision is not what it needs to be. The fellow is not there. Okay, and for years and years there, you didn't call anybody at night. It was just a second-year resident. That's unacceptable. That's unacceptable. You cannot be put out to practice medicine on your own. You're not ready yet. Heck, fire, I've been doing it for 15 years. I don't feel like I'm ready yet. Okay, I still call people all the time. So I think that it's interesting to look at this and realize that in residency training, my top priority is making sure that my residents and trainees don't feel like they're left out on their own. I think that for me, that's more important than duty hours or anything else, although I agree with duty hour regulations. All right, so we look at sleep. Sleep's controlled by circadian rhythm. So basically, we go throughout the day, we build up the hormone in our brain that causes us to fall asleep. Okay, and at some point we fall asleep, that hormone goes down, and we wake up the next morning when it's at a certain level. Okay, that's as complicated as I can understand. And I don't think it's too hard to understand. On average, we require about 8 hours of sleep every 24 hours. You got some people that can go more, some people can go less. Always heard stories of John Kennedy, only sleeping 4 hours a night. Bill Clinton the same way. You can leave what they were doing outside of that. But the reality is that we need about 8 hours of sleep per night. And I had one of those things you'll see, the Fitbits or whatever that would measure your sleep time. It would actually tell you how long. I don't know how it did that with my wrist, but I found it to be pretty accurate. And it would tell me the average number of hours of sleep I was getting per night, how long it took me to fall asleep. And I wore that thing for about a year. And as I got into about the 6th month of it, I did the plot thing on my computer, and the average number of hours of sleep I was getting a night was a little over 4. Okay, that's not good. Okay, because there's health consequences of that I'm going to cover with you in a second, not the least of which is diabetes mellitus, obesity, things that affect you outside of just being tired. And so I made an adjustment. I made a big adjustment. It really woke me up. I cannot go on 4.5 hours of sleep per night. And so now, if I had one on, I would be well over 7.5 hours, okay? Most of the time, 8.5. And I do that every night. I can tell you I feel better. Part of the reason, I guess, is I'm 48 and I can't run like I used to. But we need 8 hours of sleep a night, guys. The National Sleep Foundation said adults need between 7 and 9. If you get into more than that, and we've had patients get into more than that, then you just become a sloth. Less than 5 hours per night, you get decreased mental performance. So I was averaging, 4.5 hours of sleep at night. So I was going into every day with less, less mental performance, less mental possibilities or less mental acuity than I could have if I'd have gotten more sleep. And I'm teaching residents. I'm running a service. I was the SOS of education at the time. I wasn't where I needed to be in my job, and I can tell you I felt it as well. In our medical settings, these, things like this can be detrimental. They can be, life-altering. Make a mistake during surgery. Make a mistake writing prescriptions. Overlook drug interactions. These things are very easy to do. And I have no doubt about those numbers that say we kill 100,000 people a year in our hospital, because I think we do. And I think that we bear the responsibility for that, particularly when it comes to sleep. So decreased sleep is associated with diabetes mellitus, cardiovascular disease, obesity, and depression, and that's from the CDC. So it's not just the possibility of making errors and hurting someone else or changing the course of someone else's life or someone else's family's life. It's also detrimental to you and me. All right, so the Baldwin and Daugherty survey was done in 1998, 1999. And what these two guys did was they surveyed residents on their sleep habits. I think this is really interesting, and it wasn't an insignificant number. I mean, there's 3,604 residents completed the survey. Now, you got to remember, this is 1998, 1999. The sleep hour or the work hour restrictions did not come about until 2003, 2004. So this is pre-work hours. 20% of the residents reported getting less than 5 hours of sleep per night. Okay, 66% got less than 6 hours per night. So 2/3 of them were getting less than 6 hours at night. Already told you what that does to your mental performance. They had more incidents of serious accidents and injury. They had conflicts with professional staff. When you haven't rested, that phone call that comes from the nurse at 2 o'clock in the morning, and she's telling you Mrs. Jones has a rash on her butt, and you say, what's she doing? And they say, well, she's asleep. Then why are you calling me, right? So you tend to have a little shorter fuse, and then you wind up in these conflicts, and the next thing you know, you've made enemies out of half the hospital. The problem is you don't see it, right? You think you're behaving fine. Everybody around you thinks you're an ass, okay? So you can't see that, and that's the difficult thing, because when Dee comes to you, Dr. Stewart, myself comes to you, and we talk about it, you have to listen. There's not a conspiracy in the world among people who don't know each other out to get you, okay? Sometimes the problem is you, and sometimes the problem is this. You're just tired. It makes us more on edge. Use of alcohol. Folks who got less sleep used alcohol more. Now, I'm not against using alcohol. Alcohol's fine. Not before you go on shift and not in the middle of an appendectomy, okay? But people who get less sleep use more alcohol. Use of medications to stay awake, and I'm not just talking about caffeine. I'm all for caffeine, but when we get into things like phentermine, diet pills, those little things you see at the mini-mart stackers, I've had residents come in, their hearts jumping out of their chest. I'm going, what's going on? Well, I took 2 stackers. Well, if you looked what's in that crap, I mean, some of those things I don't even recognize, and they're selling it at the mini-mart. I mean, that ought to be a heads up for you right there. All right, noticeable weight loss. I got into this one. This was actually a benefit of no sleep. I got down to being a skeleton. But, guys, you don't want to be a skeleton. You want to be at your ideal weight, and you want to get exercise. And remember, you're always working in an impaired condition, just like a drunk driver whenever you don't have the proper sleep. All right, so this is my favorite slide. If you go 24 hours with no sleep, your cognitive performance decreases by 25%. Okay? 2 nights, 40%. Now, most of you in the room, including myself, we can't afford the 25%. There's nobody in the room because VJ Ramu's not down here. He's the only one I would put in this category. VJ could lose 40% and still be in good shape. Everybody else, I haven't seen anybody else besides VJ. All right? So after 2 nights, you've lost 40% of your cognitive ability. So this is the Epworth sleepiness scale, and it's a scale that we use to diagnose things like narcolepsy and sleep disorders. So there was a study done where they took a group of residents and put them through the Epworth sleepiness scale. And they found out that residents can score about the same on the Epworth Sleepiness Scale as people who have a diagnosis of a sleep disorder. Matter of fact, 84% of residents in one study were in the range where treatment for a sleep disorder was indicated. Okay, now these are pre-work hours, but guys, we still do some of the same things. We may not be working as much, we may not be in the hospital as much, but it's how we spend our time outside of the hospital, how we spend our downtime. It's not optional. It's a physiologic need, and if you don't have enough of it, it will impair your function, I'll guarantee it. Oh, yeah. So what you can't see up top says everyone, including faculty, needs to understand, because the problem that we have with work hours and sleep restrictions is usually not our residents. It's our faculty. If Thad's been up for an excessive amount of time, he's tired, he didn't think he's making good decisions, and I'm the attending, he is in a very vulnerable position to come to me and tell me that. Because if he does, he's going to think that it'll affect his evaluations, that I don't think he's a hard worker, right? I mean, that's what everybody, you say it, I know it's true. So you're in a very vulnerable position. So our faculty have to be educated on that. And so we got Dr. Stewart and Dee, I know will, but we have faculty who doesn't believe in this. We have faculty that thinks, and I've had to deal with them to VA. Well, you know, back in my day, my rule of thumb is when I'm up talking to a group of faculty members, and one of them raises their hand and says, when I was in residency, I stop them right then. That ain't got crap to do with what we're talking about. All that stuff is off to the side. You're in a very vulnerable position, and I'd encourage you, if you're having issues in this area, go to your program director, because that's the person that's most equipped to handle it and will have the support of the chair in dealing with faculty. We need to be able to recognize signs and symptoms of fatigue, especially those that are nonspecific, and I'm going to run through some of those with you here in just a second. Altered mood, apathy, right? Just not caring. If you get to that point, you're in trouble. Impaired memory. I remember this. Remember having times in the hospital where at the start of the shift I could remember everything, right? I knew what the patient's hemoglobin was yesterday. I could run through the CBC in my head. I didn't have any problems at all. Towards the end of the shift, I was having trouble remembering, what the last potassium was in a DKA patient. Okay, when you start to feel those slips, then you're getting tired. That is a sign. Inflexible thinking. Now, I don't know how accurate this one is, because all of us are inflexible to some degree, and the surgeons, I don't know how in the hell they would ever tell. Okay, but inflexible thinking, when you get in your own mindset and not taking feedback from anybody, that is a bad sign. Nodding off, little micro sleeps, I'm going to talk about here in just a second. Those are bad signs. Medical errors, you find yourself writing a medication and you use the wrong dose, or maybe that dose doesn't even exist, or you misspell the medication and it turns out it's one of those lookalikes or close, and you write the wrong medication. Medication errors are always bothersome for fatigue. And then again, microsleeps, which I'm going to cover right now. Microsleeps are these, and probably everybody in the room has experienced these, and the place you really have to watch out for them is if you're coming off night float and you're on your way home. Okay? Even though you may have gotten rest during the day, you still were up most of the night, and that's not, whatever built us, that's not how they built us. Okay? So you pull up to the red light, and then you're sitting there, and some guy behind you beeps the horn for you to go on. Right? You sit there, you've nodded off a little bit, and then you shake yourself. Or you get all the way home and you don't remember the drive. Okay? Everybody's done it. Those are microsleeps. Microsleeps are dangerous. They're dangerous when you're behind the wheel of a car, and they're darn sure dangerous when you're in the middle of somebody's abdomen in surgery, or you're taking care of patients in the ICU or on the floor. They can cause lapses of attention. If you're not awake at the red light, the guy behind you will let you know with his car horn. Okay, we have to kind of be the car horns for each other when it comes to this. If you see people nodding off, now there's nobody else in here. So some of you were having some micro sleeps when I walked in. All right, I saw them a little nodding off, and some of you may have been just about asleep. I won't point out those folks, but we do have to let each other know, and we have to be receptive to that feedback. If you're repeatedly checking your work, did I make an error? Go back and look at it. I don't remember doing this. A bothersome sign for micro sleep. So, in a resident, you should treat excessive sleepiness and fatigue as a performance issue. It's a performance issue, but guys, performance issues are how we get better. I didn't get better in my life ever until I had somebody stand in front of me and say, Steve, these are the things that we see. And this, and this. And these are the things that you need to do to get better. Guys, people who do that for you are trying to help you. I assure you there's nobody in your residency program or in your hierarchy at the medical school that doesn't want to see you be successful. So you have to be willing to listen to feedback. Okay? So if they come to you and they said that there's a problem, that people have noticed this or noticed that, don't shut it off right off the bat, because I told you one of the things is you aren't aware that you're doing it in the first place. So listen to feedback. There's nobody here inherently out to get you, and you can definitely come back from performance things in residency. There's no question. I have performance things in residency. I've still got evaluations where I needed to do things. I never got put on probation, but in all reality, I probably should. Okay, so don't take those things as somebody out to get you. They're not out to get you. They don't get paid extra if you don't pass. Matter of fact, it's a bigger pain in the rear end because they got to find somebody to cover for you. Okay, so listen to feedback. Realizing that it may be a medical problem. Hypothyroidism is the easiest one to think of, but depression, we know that 10 to 15% of everybody in a medical profession will have an issue with some mental health ailment during their lifetime. Okay, it's not a cloak of shame, and I can promise you can come back from them. But you have to be open to listening to people when they tell you what they see. Medication, if anybody's on beta blockers, that is a well-known medication. Or you could have a primary sleep disorder. Narcolepsy, or way more common, would be something like obstructive sleep apnea. Okay? So understanding our role as residents, colleagues, me as a faculty member, we don't need to diagnose and treat. I'm not a sleep expert. I can give you this talk. I can give you some things that will help you mitigate the effects of sleep loss, but I'm not an expert. I'm not going to diagnose you, and I'm darn sure not going to treat you. What's our job? Our job is to identify it. Our job is to do what we're charged to do as physicians, and that is watch out for the well-being of ourselves and watch out for the well-being of our colleagues. I say this all the time. We're the only profession I know that's still allowed to police itself, and we have to do a better job than what we do now, because right now we always think, well, I'm going to hurt such and such's career, or I'm going to, they won't get this residency spot or this fellowship slot. Guys, all that's bull crap. If somebody is hurt as a result of that, then you're just as negligent as they were. Okay? And we need to refer to the appropriate source. I can tell you, for you all, it's your program director. Employee health services in your hospital. All right. We're not going to be able to eliminate fatigue, but we can manage it efficiently. If you look at program solutions we've had through the years, Night Float was one of them. Night Float was going to take care of this. I don't care. Night Float ain't taking care of anything. Right? It's increased our number of handoffs. And maybe a little bit better care in the night, particularly when you have an attending in the house for you. But Night Float has not fixed the problems, and sometimes they're associated with even more issues because we have more issues around patient safety concerns with handoffs than we do with sleep and fatigue. And it exposes a resident to all the risk associated with fatigue. I don't care. I've had shift workers that have worked graveyard shift for 20 years. They're still sleepy during the day. You never adjust. We weren't built to adjust. We were built to look at sunlight, wake up, see dark, go to bed. Okay, folks that live in Alaska, where half the year it's 12 hours of daylight and half the year it's 24 hours of daylight or 24 hours of dark. They don't adjust. Okay, you don't adjust. It's always going to be there. All right. The challenges with night shifts are sleeping during the daytime. Those of you who go home during the day, and Joe May works nights for us at the VA. I always ask him about that because Joe loves his kids and he's all the time doing stuff with them. It's difficult to sleep during the day. There's noise during the day. You see sunlight, it activates your pineal gland. I mean, it's difficult to sleep during the day, period. It's difficult to staying awake at night. If you're driving at night, even coming home from vacation a couple of weeks ago, you're driving at night. Even though I'm fresh and I'm ready to go, I just had a nap. It gets to be between 2 and 4 in the morning. I can't hold the car on the road. Right? It's very difficult to stay awake that late at night. Using caffeine pharmacologically, which I'm going to teach you about here in a second. And then recognize that no adjustment can be made. As I told you, you do not adjust. Even lifetime graveyard shift workers don't adjust. All right, so let's talk about prophylactic naps a little bit. Before a shift, the best thing you can do, if you're, if it's particularly maybe a VA night rotation, Johnson City Medical Center night rotation, take an hour nap before the start of your shift. When they surveyed residents after taking an hour nap prior to their shift, they subjectively experienced less stress and they felt like the workload was less burdensome. If you go into that tired, the workload is going to be very burdensome. I was really tired yesterday. It was my first day back from being at the beach. I'd had it up to here with a couple of ER docs. Okay, I was tired. I didn't get enough sleep the night before, and I can tell you that I was stressed. If I'd have been better rested, then I would experience less stress with the same things around me happening, because I fired off a couple of emails I'd like to have back right now. Thanks, Thad, for helping me with one of them, by the way. I didn't fire that one off. It's a subjective thing. So if you take an hour nap prophylactically, that's usually the best thing to do. It's better to limit your night shift to 1 or 2 nights. And guys, some of this stuff you're not going to have any control over. But what I would look at in the night float system as we go forward is having you switch off every 2 nights. I think now we work 3 to 4 nights, and I get it. You like that better. You get more. But it's better to do it in 1 and 2 night stretches. If you're going to nap, take mid to late afternoon naps and use caffeine. And I'm going to tell you about nap timing here in just a second. All right, here's caffeine. Guys, it takes about 30 minutes for caffeine to have an effect, and it lasts about 3 to 4 hours, and you can build a tolerance to it. Now, I don't drink sodas anymore, but back in my soda drinking heyday, I'd drink about 14 to 20 Diet Cokes a day. And that's probably a little much, right? I'm about to break a chromosome. All right, so I don't want you drinking that many. But it takes about 30 minutes to have an effect, 3 to 4 hours. Tolerance can develop. You've got to remember that it's a diuretic. Okay, so if you're pounding down the caffeine at 10 o'clock and you're on your last patient, stop doing that. Okay, stop doing it. Sometimes it's hard to foresee, but you got a chance of getting some sleep. You're not going to be able to get sleep because you'll be peeing all night long. Okay, it is a diuretic. And always avoid alcohol. First of all, you can't come to work with alcohol on you. I don't care what you do in your off time. You can't ever have that. I don't care if it's from the night before or 2 nights before. If it's 2 nights before, you need to check yourself in somewhere. All right, napping during on-call hours is helpful. It is helpful. The timing of it is going to be crucial, though, because we want to nap not during our normal sleep hours, because when you do that, you tend to nap longer than you think you're going to. And if you go past about 20 to 30 minutes for a power nap, you get into an hour, you get into something called sleep inertia, which I'm going to teach you about here in just a second. Dadgummit, I hate not being able to see it top of. All right, here, when to nap. Banking sleep helps. If you get a chance to take a nap, go ahead. I don't care if you're not even tired. Banking sleep helps. During the afternoon is the best time. Power naps, 15 to 20 minutes. And guys, this one is, those of you who power nap know this one to be true. 15, 20-minute nap, you feel like you're ready to go. Now, you may wind down, but you're going to feel cranked up and ready. During your normal nocturnal sleep period is tough, because your normal nocturnal sleep period, you're used to laying down and going to bed for hours, going to sleep for hours on end. Now, always take the chance to nap whenever you can, even if it's in the times that I tell you not to. Okay? It's always better to take a nap than not take a nap, but just realizing at nighttime it's difficult because you'll stay asleep longer. And those of you who've done that, and you wake up, like a Sunday afternoon, I slept most of the afternoon, and I got up, I felt like crap. And I felt very, very tired and run down, and it probably had something to do with why I didn't sleep well Sunday night. Nocturnal naps may result in something called sleep inertia. Okay, and I had sleep inertia happen to me once, and I'll tell you about it as soon as I describe it to you. Sleep inertia gives you impaired cognition and severe disorientation. There's a transitory hypovigilance. And so if you've ever seen somebody manic, right, they've been up for a couple of days in a row, they have this hypovigilance about them. It's almost obsessive compulsive about things, and they have all kinds of energy. They're confused, have a difficult time getting fully awake, and it lasts up to 30 minutes. Many people overestimate their ability to function in this state. They don't realize anything's wrong, and it'll take about 15 minutes to counter the effects. I got into this one night at JCMC in my PGY2 year, and the call rooms used to be on the 7th floor. I don't know if they're still up there or not, but they're excessively dark. I mean, it's unbelievably dark in those call rooms, and I wore contacts that night, and we didn't have any patients, and so I thought I'm going to get a good night's sleep. So I get undressed, get in my bed, take my contacts out, and go to sleep. Well, a couple hours later, there was a code blue. And so I jump up immediately. The room is unbelievably dark. I can't find my glasses. I don't even know if I brought my glasses. I said, to hell with it, and I hit the door because I was headed down 2 flights of stairs down to 5500. And I got down there, and I walked in the room. My intern was in the room already taking care of the code, and everybody stopped and looked at me. And I thought, well, my hair's messed up, or maybe my breath smells bad. I didn't have on any pants. Okay, so I got 2 floors down the steps. And I had on some very nice boxer shorts, though. They had University of Tennessee stuff on. I didn't have any pants on. All right, I was experiencing sleep inertia. I didn't have any clue because I was wondering why everything stopped. So this, it's funny, but the reality is I was, probably guilty of some kind of sexual exposure, and didn't have any pants on. Right. So if I wasn't aware that I didn't have pants on, I used to have that dream when I was a kid that I went to school and didn't have pants on. Well, that happened to me. Think about how good I was at the code in that situation. It's a good thing that my intern was Heather Chatton. Heather handled the code, and I went and put some freaking pants on. Okay, you have to be careful with sleep inertia because it happens to us, and it's like a drunk driver. They always overestimate their ability to drive. Okay? 40 to 60-minute naps have shown more slow-wave sleep. When you get into that 40 to 60-minute time, more slow-wave sleep, the more at risk you are of sleep inertia. Just try to keep them under an hour. How do you combat sleep inertia? Get vertical, stand up. Daylight, seeing daylight's the best thing, but if not, artificial light will work. Take a shower, do jumping jacks, and plan to recover from sleep inertia. I'd never had it happen to me before, but I had a code situation. It was immediate. I didn't have time to do all this, plus I didn't know about any of this stuff. All right, what's sleep debt? Sleep debt is the time we need, so 8 hours, minus the number of hours of sleep that we get. So if I get 4 hours, my sleep debt is 4 hours. Sleep debts are associated with slower response times, forgetfulness, confusion, depression, lack of motivation, and decreased morale and initiative. If you think about your days, the days that your morale is way down, the days that they're just slugging on you, and this even cycles with times of year. You get into a mid-February evening, you're way down at the nadir, okay? And not getting enough sleep will make that worse. You'll become a complainer. You'll be involved in administrative wars, the full gambit, when really what you need is some rest. All right, the worst nap time is between 8 and 10 p.m., okay? Why is that? Because that's normally the time that we all go to bed, or at some point in our lives we do as you get older. But remember, any nap is better than no nap. Pre-shift and on-the-shift naps can help manage fatigue. They cannot take the place of time off. I said, well, I don't need any time off. I used to do this when I first got started as attending. I don't need any time off. I got some rest here. I got a nap there. You cannot cover multiple hospitals at one time when you get out of residency, guys. It will drive you in the ground, and your home life will deteriorate, and you will suffer physically yourself. Time to recover after you've been up all night. About 2 nocturnal sleep periods it takes. 36 to 48 hours off is ideal. That's not going to happen during residency. Okay, so you'll just have to deal with that one. The longer the sleep time, the better, except for when you're in a sleep inertia situation. And use your time off to keep up with sleep. You've still got the family responsibilities, but always lead with that because that's difficult. I remember in medical school the first time my wife fussed at me for studying. I can understand if I'm in Vegas, I hang out all night drinking, okay? If you want to fuss about that, fine. I'm studying. You're fussing at me for studying. I hated studying. Right? And everybody in the room who's got a significant other probably has experienced that. This is a very difficult balance. Don't forget about your family. Free time. Use it responsibly. You can go to the Electric Cowboy, just don't go 5 nights a week. Resident-friendly programs should reduce the non-essential things you do. It's what I'm always working on, getting rid of those things that I don't want you doing, the numerous phone calls that don't matter that you get. There's a reason for that. I want you focused on the things that you're going to make a difference at and not these things that are draining you. Nurses should eliminate inessential phone calls. I'm going to go ahead and go to the next one. Evaluate your need to moonlight very carefully. When you get into your 2nd and 3rd year residencies, if you have a medical license and a DEA number, you can get moonlighting jobs. I encourage you to be very careful with that. First of all, you've got to count those hours towards your duty hours. And second of all, that is a very dicey situation to get started in because you already have more than a 40-hour work week. And a lot of times you'll do it on the weekends. You need those weekend times to decompensate, spend with your family. So understand the need of the money. I get that, but weigh it very carefully. Beware of the drive home. Find yourself closing your eyes at traffic lights. You can't remember if you got, how you got home. Continuous yawning, shifting lanes continuously. Those are all bothersome signs. These are a few of the myths. Chewing gum don't work. Okay, it never does work. Turn the radio up loud doesn't work. Sticking your head out the window and let cold air hit you in the face does not work. None of those things work. Yet we see that all the time. It won't help you. If worse comes to worse, call somebody to come and get you. I'll take you home. I got no problem with it. All right. We're never going to eliminate sleep and fatigue as an issue, even with the ACGME standards. We need to try to manage it as effectively as we can. I talked to you about naps. I talked to you about use of caffeine. You've got to recognize the serious side effects and take naps to reduce adverse outcomes. Remember, any nap is better than no nap. 20 to 40 minutes is ideal. Got it? Those things you can take home. And the other thing is, this is Andersonville Prison, the most notorious of the Confederate prisons in the Civil War. We can't stand over you and watch. You have to take responsibility of this for yourself. So, with that said, we got done a little bit early. And guys, thanks for having me. And if I can see you, we'll take care of your stuff. Thank you.